Good afternoon, everyone. It looks like we still have folks joining, so we'll give it another minute before we get started. Good afternoon, everyone. Thank you so much for joining us today for a listening session on the Quality Payment Program and Advanced Alternative Payment Model Initiatives. We really appreciate you taking the time and hope that it's a really useful session both for you and for the CMS Innovation Center. My name is Ellen Lukens, and I am the Deputy Group Director for the CMS Innovation Center. I'm joined today by Ann Rabel, who's the Division Director for Alternative Payment Model Infrastructure. And also I'm joined with other colleagues from CMMI. Ann and I will serve as today's facilitators. And before we get the discussion started, I did want to just provide a few updates on administrative items. The first is to let you know that this session will be recorded. The second is that closed captioning is available for this event by clicking the CC button at the bottom of the screen. If you have any issues with that, please just send us a note in the chat. Third, I want to point out that we do have a Q&A function available to us during this meeting. And I encourage you to put in questions, comments, anything else you may have for us. Due to the size of the event, we may not be able to respond to everyone's questions, but we'll be monitoring it closely and capturing any follow-ups there. And these are really helpful for us just in terms of future communications, understanding what some of your questions are. For example, if we decide to do frequently asked questions or a resource like that. Lastly, if there's any press on this call, please submit questions through the CMS Media Inquiries portal. And that link is being shared now. You should see that right now in the chat. I just saw it pop up. Next slide, please. Again, welcome to the CMS listening session on alternative payment models and specifically the APM incentive payment. We are really grateful to you all for making time to engage with us on what the CMS Innovation Center, or CMMI, is doing to strengthen alternative payment models within CMMI. A special thanks to our panelists for joining us today. We really appreciate it. CMMI was created in 2010 as part of the Affordable Care Act, as I'm sure most of you know, with the goal of transforming Medicare and Medicaid into a more value-based healthcare system. Today's panel stems from the Innovation Center Strategy Refresh White Paper that we released in October. And if you want to take a look at that, that link still continues to be on our website. And that strategy paper really detailed our vision for attaining a healthcare system that achieves equitable outcomes through high quality, affordable, person-centered care. And that really is our vision guiding the next 10 years of the Innovation Center. This strategy is closely aligned with CMS's broader strategy and goals for the agency. Key elements of the Innovation Center strategy link back to the agency's broader agenda to make sure that we collaborate with our partners across the industry to achieve a larger vision for our beneficiaries and enrollees. Today's panel is a part of a series of listening sessions and really reflects our commitment to greater stakeholder engagement and transparency. We want to hear from you. We want your input to understand your perspective on some of these critical policy issues. As you are probably aware, some of the content we will talk about today is included in the physician fee schedule. And so any comments you provide there will be your official comments on the proposals. This is an opportunity, again, for us to hear from you, from providers, from participants in APMs on their perspective on the forthcoming end of the lump sum APM incentive payment. We want to receive continuous feedback from all of you. on how we can better achieve meaningful transformation of our healthcare system. The CMS Innovation Center certainly has more work to do. And I feel strongly that we can learn a lot from you. And many of you may have thought about being in APMs or have experience being in APMs or have, maybe not dipped your toe in the water yet. And I think there's a lot we can learn from all of you on your perspective on the Innovation Center and how we can best support you. Now I will turn to today's agenda. Next slide, please. Thank you. On Thursday, July 27th, 2022, CMS published a new rule with updates to the quality payment program that will take effect in 2023. These updates include changes to the physician fee schedule, advanced APM incentive payments, and MIPS payment adjustments. Today, we will provide a more detailed overview of the quality payment program timeline. We will then review a comparison of the physician fee schedule conversion factors versus the maximum MIPS payment adjustments. Finally, we will facilitate a panel discussion to hear perspectives of experts on the ground. And in this discussion, we will be hearing both from physician representatives as well from folks who have experience with both ACOs in bundle payment models. So I think a really diverse and interesting panel. We sincerely appreciate your time and thoughts so that we can all be working together to shape a healthcare system that best serves our communities. So we really do want to hear from you, your perspective. Before we move to the quality payment program timeline, we have 2 short polls we'd like to ask the group. To register your response, please select the best option in the window that will pop up on your screen. And I hope you're seeing this now, it popped up on my screen. So the first polling question, what is your organization's participation status in an advanced alternative payment model? And you essentially are supposed to respond to only one. Participating and planning to continue to participate, participating, however, planning to no longer participate, not participating, however, preparing to join, not participating, however, discussing what it will take to join, not participating, and have not discussed joining. We will give you a few minutes to answer the polling question. We will now actually go to a second polling question, which has to do with the level of current understanding and engagement. So polling question number 2, please indicate your level of agreement with the following statement. My organization is familiar with and prepared for upcoming changes to incentives for qualifying APM participants in the next few years. And in terms of QPs, those would be folks who are participating in advanced APMs and meet the thresholds to qualify as QPs. The choices are strongly agree, agree, neither agree nor disagree, disagree, strongly disagree, or does not apply to me. We'll give you a minute to answer this before we go to the next portion of our program. Thank you for all of your responses. I will now pass it over to my colleague, Ann Vrabel, who's the director of the Division of Alternative Payment Model Infrastructure at CMMI. Next slide, please.
Thanks, Ellen, and hello, everyone. So the timeline that you're looking at shows the progression of QPP relevant financial incentives starting with 2016. Conversion factor updates are legislative. So for example, you can see how Congress increased the conversion factor update last year to help address the COVID-19 public health emergency. QP incentives also are legislative, and those stem from MACRA, the Medicare Access and CHIP Reauthorization Act of 2015. Specifically, QPs are excluded from MIPS, and that's across the board, so that will not change over time. In 2019 through 2024, they also received the 5% APM incentive payment. In 2025, QPs only receive that MIPS exclusion, so no financial incentive. And then from 2026 forward, MACRA adds a higher conversion factor update for QPs than for non-QPs. MIPS adjustment, which in this table are showed in simplified numbers, have maximum windows that are established in MACRA, which may or may not match what actually ends up happening in implementation. You can see that those maximums grow to plus or minus 9% over time. And again, those are in statute. Next slide, please. So first, I want to emphasize with this slide that you should not rely on the numbers shown here as real estimates of payment rates. This graphic is a mock-up that very much simplifies the involved math, and it's intended solely to illustrate the general relationship between the differential conversion factor updates and the MIPS adjustments to provide context. The conversion factor updates are shown in solid lines, and the maximum MIPS adjustments are represented by dashed and dotted lines. For purposes of this illustration, we took the 2020 single conversion factor update shown in the physician fee schedule, and we grew it to create a mock 2025 single conversion factor as a starting point. From there, we used simplified math to show the direct effects over time, specifically the compounding and spread of the differential conversion factor updates for QPs and non-QPs. And as you can see, initially the higher end of MIPS adjustments may result in larger financial incentives than QPs will earn through their enhanced conversion factor alone, which is an effect that will diminish and ultimately disappear over time. Please note that there are many different factors at play for each piece of these calculations, so we can't predict with perfect certainty when exactly the QP conversion factor would overtake maximum MIPS adjustment, which is why we are only demonstrating a simplified illustration here. So for example, if we were showing you this back in July 2019, we would not have been able to predict at that point that 2021 would feature a 3.75 conversion factor update to help address a public health emergency. We did not see COVID coming in July of 2019. So we can't really know what this will end up looking like in practice. But this chart really is meant to show you the general concept of how the conversion factor updates and MIPS adjustments interplay generally. And it's with this interplay in mind that we recognize that clinicians or organizations may be considering QP status differently going forward than they have in the past. And we want to hear more around how these changes in MACRA's incentives might affect decisions about joining advanced APMs or continuing participation and really for attaining that QP status. I also want to note that we included a request for information relating to this topic in the physician fee schedule NPRM that Ellen mentioned, and that is posted at the Federal Register website and scheduled to publish next week. So as Ellen mentioned, please do submit comments to that before the close of the comment period. So with that, I'm going to introduce our panel of speakers today, and we can move to the next slide, please. Okay, so we think it's critical that we reach out to experts in the field who can inform our work and make sure we are hearing from as many leading individuals and organizations in this space as possible. So we're pleased to welcome several leaders from APM research organizations, as well as experts from specialty associations to take part in a panel discussion on planning around the end of the lump sum APM incentive payment and moving to conversion factor updates under the physician fee schedule. Joining us today are Aisha Pittman, Senior Vice President of Government Affairs with NACOs, the National Association of Accountable Care Organizations, Jessica Walrad, Director of Performance-Based Reimbursement and Value-Based Care with Northwestern Medicine, Sandy Marks, Senior Assistant Director of Federal Affairs with the American Medical Association, and Karen Haggerty, Chief Regulatory Affairs Officer, Association for Clinical Oncology. This group brings a diverse set of experience across advanced APMs. They will all get an opportunity to touch on each of the subjects we discussed today in order to obtain as much of their unique perspectives as possible. During the panel, the group will focus on 3 questions. What are the most important questions that you or your members consider in deciding to participate in an advanced APM or any APM? And how important is the APM incentive payment in affecting your decision to participate. The second question is, how will the end of the 5% lump sum APM incentive payment beginning in payment year 2025 for performance year 2023 affect your organization? And then the final question is, are there perceived advantages of participating in MIPS versus participating in an advanced APM? We will also have one more polling question, so do look out for that coming up. Next slide, please. So our first question is, what are the most important questions that you or your members consider in deciding to participate in an APM? And how important is the APM incentive payment in affecting your decision to participate? So for this question, I will take the panelists just in the order they're shown on the screen here. So Aisha, we will start with you.
Thank you. And I just want to first start by thanking you, Anne, and Ellen, and the rest of the CMMI team for hosting this session on this really critical topic. For context, NACOs represents more than 400 ACOs, and ACOs make up roughly 93% of the clinicians receiving the advanced APM bonus. So of the clinicians receiving the advanced APM bonus, 93% of them are receiving it because they're in an at-risk ACO. So it's a really important topic to us and our membership. To take the second part of your question first, how important is this? We surveyed our members in 2020 and getting about responses from over 100 ACOs, 84% of them said this was extremely important. It's very much top of mind. The decisions of how to go into an APM and an at-risk APM are really quite complex, and it gets to a few different things. One is the base model that you're going into. We all know that the value-based care models provide additional flexibilities that are much better than fee for service, and that you can really innovate care and change care practices in a way that benefits your members. So things like the waiver of the 3-day hospital stay for moving into a skilled nursing facility, that's a really critical benefit to those in advanced APMs, and that you are ensuring that your beneficiaries are getting the right care in the right place at the right time. Models like ACO Reach have a whole host of other benefits that consumers find important, like being able to shift the cost sharing on things, having other services like transportation services, wellness program. All of those benefits are things that providers really want to offer their patients. And the advanced APM models have the most flexibility to change care. And so that's a huge consideration for if you move to an at-risk model. But I'd be remiss without saying that the finances are an incredibly critical component as well. Taking on risk is a significant financial decision, and ACOs are really looking at that as well. There's sort of two components to that. One is the investment costs. Over the past decade of being in these models, we've learned a significant amount about the investment required to move into an ACO. We've surveyed our members and the startup costs. The average operating costs are around 1.6 million per year, and the startup costs range from 2 to 10 million, depending on your ACO's characteristics. There are some incentives, and we appreciate the incentives for startup costs like we see in the advanced investment payment model that was included in the recent proposed rule, but there's ongoing costs. And when you move from an upside only model to an at-risk model, you also have additional costs, because that move to at-risk, with the more flexibility that you have to have other processes in place. This is another area where we surveyed our members and asked, how they're taking that advanced APM bonus and reinvesting it. And it's going into things like new EHRs, additional staff, care managers to help coordinate care, physician dashboards, data analysis systems, telehealth platforms. Those are all sort of the additional infrastructure you need to better manage care when you're at risk. And so those investment costs are critical, and the advanced APM bonus has been helpful in addressing those investment costs. I think the other financial consideration is the underlying payment incentive structure, and I know we'll get to that in a bit when we think about the incentives under MIPS versus advanced APMs.
Great, thank you. If if I can just pull on one little thread there, at the end you were talking about using QP financial incentives as a way to sort of reinvest in the sorts of things that can advance your organization over time. So really that ability to kind of keep the train moving by reaping those benefits sounds like it's an important piece as we go forward.
Yeah, and if I can just quickly add one thing I also forgot to mention is just the other piece is because you can have these investments, is a great physician recruitment tool to get more clinicians into the models. And so the advanced APM bonus has been a really great recruitment tool to bring more folks into risk.
Thank you. Jessica, I will turn it over to you to answer this question. Most important questions you and your members consider in deciding to participate in an APM, and how important the APM incentive payment is in affecting that decision.
Yeah, thank you. And I'll echo Aisha's thanks to you all for hosting the event and for the opportunity to present. As stated earlier, I'm speaking on behalf of Northwestern Medicine, and we participate in a MSSP ACO, and we've been engaged in episodic care models for COPD, heart failure, sepsis, stroke, major joint replacement of the lower extremity, and cancer via BPCI advanced in the oncology care model. So my comments are heavily informed from our participation in those models. I'll start out addressing this question with a little context that informs the perspective of Northwestern. So Northwestern is an 11 hospital health system, and we have 2 employed multi-specialty group practices, which between them have close to 3,000 employed physicians. And one of those groups predominantly practices on our academic medical center campus. So a tremendous amount of the care provided is for patients who are seeking acute specialty services. And as a result of that, it's been extremely difficult for NM to achieve the APM entity level QP status. I know that the recent physician fee schedule proposed rule acknowledges that challenge and is discussing the prospect of making QP determinations at the eligible clinician level. And if that policy had existed historically, it definitely would have weighed predominantly in our participation decisions. But putting that aside, there are a lot of factors that guide how we assess program participation. So if you can get an incentive payment or not is just one component of many. First and foremost, we ask the question if the model aligns with the care goals that we have for our patient population. Assuming it does, the next step is to assess the overall financial opportunity versus risk. And there are a lot of components that go first off, looking at the benchmark or target price methodology. That's, of course, a really complex topic that deserves its own series, but for the purposes of time, I'll boil it down to one sentence and say, essentially you want a financial target that is incentivizing positive change, but is adequately risk adjusting for the factors beyond a clinician. The second thing we look at is volume. So is the volume high enough, or is our attributed patient volume high enough so that we have adequate risk pooling? We don't want our results to be disproportionately impacted by a few outliers. We look at our ability to impact results. So for a given program or contract, do we see a path to success? And do we have interventions in process, or at least identified, that are going to support that path? Fourth would be thinking about the administrative burden. Many of these programs have data submission requirements, quality reporting, some have requisite billing changes. And so we have to ask ourselves if the resource costs associated with those requirements are manageable, or are they too much that isn't worth the squeeze? And then finally, the implementation time. Is there enough time to establish and execute an implementation plan that is going to set us up for success before a model starts, or at least before downside risk kicks in? So yes, the APM incentive payment is an important consideration, but it's one of many that we look at when thinking about whether or not a certain model makes sense for Northwestern.
Okay, thank you. That makes a lot of sense. And it's interesting to hear how something like the administrative burden really does play a role. We do sort of internally try to acknowledge that and talk about there are different degrees to which that may or may not matter depending on the organization and their needs and the clinicians at play. So it's good to hear. We have two of our 4 speakers have gone, and we already have such diverse layout of considerations and weights. So Sandy, I will turn it to you from here to answer that question.
Thank you.
Hear from the AMA.
Thank you. And thanks also for having this session and for inviting us to participate. Instead of going to, a whole new path, I actually want to pick up on what Jessica said. I think what we found is that the most important criteria for physicians as they decide whether or not to participate in an APM is whether that APM is going to give them the ability to deliver higher quality care for their patients than they can under the current payment system. So I think that aligns totally with what Jessica just said. The current system creates a lot of barriers that prevent physicians from improving care. One is that there's often no payment available to support the kinds of services that would improve outcomes and reduce spending. So for example, many patients who come to an emergency department with symptoms like chest pain or dizziness could return home rather than being admitted to the hospital if the emergency physician could be sure the patient would receive the necessary assistance to return home safely, and that the patient could receive prompt follow-up care from a primary care physician. But Medicare doesn't pay emergency physicians for the time they need to locate the patient's primary care physician and develop a coordinated discharge plan, or to hire a nurse or a community health worker to help the patient return to their home safely. So as a result, the only safe option may be to admit them to the hospital. The American College of Emergency Physicians developed an APM that would fix this problem by paying for these discharge and transitional care management services. And although that APM was unanimously endorsed by the PTAC, the model has not been implemented. As a result, patients continue to be admitted to the hospital who might otherwise have gone home. So this likely disproportionately affects patients who have health-related social needs and contributes to health inequities. Many of the APMs that have been implemented don't really address the barriers in the current payment system. So the 5% incentive payment has been a key factor in physicians' interest in and even in their ability to participate in the Medicare APMs, as they cannot otherwise cover the costs of participating, handle the downside risk, or deal with the revenue reductions that can occur from reducing avoidable services.
Okay, that is really helpful to hear about those different considerations, particularly at the sort of the individual clinician level. So thank you for that, Sandy. And Karen, I can turn it over to you to close out with this question.
Well, thank you very much, and good afternoon, everyone. And I would like to echo everybody else's thanks to CMS for holding this session. So I am with the Association for Clinical Oncology. We're a national medical specialty organization representing nearly 45,000 physicians and other healthcare professionals specializing in cancer treatment, diagnosis, and prevention. And so to address the question of, what are the most important questions or that people think about when looking at APM participation in terms of our practices, what we hear from them, and I'm going to divide this into 3 broad buckets, and you're going to hear a lot of commonality, I think, with what Jessica said. First, how does the APM align with the goals of the practice in clinical cancer care delivery? also looking at the administrative requirements and costs, and then the financial risk of the APM itself. So in terms of APM alignment with the goals of practice, they're looking at things like, does it align with their goals of care and practice transformation, the effort to achieve higher quality, health equity, including social determinants of health, related social needs. In terms of the administrative requirements and costs, it needs to be recognized that a lot of these models require quite a bit of extra clinical data reporting, and quality data reporting is fairly significant. And to use the oncology care model as an example, practices reported to us that they used much of their MEOS payments, which was the extra monthly per patient payment that they received, simply to meet these administrative and reporting requirements. They had to hire extra staff, et cetera. And then in terms of the financial risk of the APM itself, which does become even more significant with the loss of the 5% bonus, the administrative requirements and costs of these models continue to increase. And again, looking at the OCM, the oncology care model experience, out of the roughly 200 initial practices that signed up, I think 45 eventually elected two-sided risk in the OCM. And this was with the 5% bonus that was helping to offset those administrative costs and financial risks. And we may talk more about this later, but so this definitely concerns us in terms of people thinking about the new enhancing oncology or EOM model that CMMI is rolling out. If people do not have access to this 5% bonus, we've had members tell us that they're probably going to be much less likely to participate without the 5% bonus. So I'm looking forward to discussing this more with the group.
Okay, great. Thank you for that question. And I did see a question in the Q&A I wanted to address. So there was a question about when the APM incentive payment is going away. Under MACRA, the APM incentive payment is given in payment years 2019 through 2024, and that corresponds to participation years 2017 through 2022. So in payment year 2025, corresponding to 2023 performance year, is when the APM incentive payment is slated to end. And again, that is in legislation. So I wanted to move to the next poll question that we have for everybody before we move on to our next question. Okay. So this polling question is looking to take your temperature around continued participation. And I think it piggybacks really well off of the last remarks that Karen just made. My organization would appreciate being able to participate in an advanced APM and decide for ourselves whether we receive a QP determination, even if that means CMS would make changes to APMs that would require us to take additional steps to notify CMS of this decision. So this is really looking to see how interested you might be in sort of owning whether we make that QP decision for you. And the choices are strongly agree, neither agree nor disagree, strongly disagree, or does not apply to me. Okay, thank you all for participating and providing us with your feedback. Now we would like to transition to our second discussion question. So we can move to the next slide, please. Okay, and I think we've already heard a little bit from you on this issue, but to get more deeply into it, how will the end of the 5% lump sum APM incentive payment beginning in payment year 2025 and performance year 2023 affect your organization? So Aisha, I will start with you once again.
Thanks. So I think for ACOs and these who are qualified as QPs, it's a really decision of priorities for moving forward. You heard from everyone else about the investment that they make back into patient services. So as I've talked to ACOs, the lack of the bonus is really going to translate to eliminating certain patient programs that they've had in place for a very long time. Also eliminating some of those other investments. This ties back to some of the base elements of the program. When things change in a particular model, for example, in MSSP, there's a change to the quality score that's going to require a significant IT investment. Losing that bonus then also makes folks think, do we stay at risk, or do we try to do some sort of other model? Do we drop out of the program completely? I touched on the piece about the clinician recruitment as well. The 5% bonus has been really attractive to get those that are already in ACOs to move from the upside only approach to being at risk and going at risk much more quickly. And so combined with some of the proposals that we think are positive with slowing risk, I think there's going to be less urgency of moving towards risk-based models and being able to recruit clinicians into those risk-based models.
That makes sense. Thank you. And Jessica, I will once again go to you.
Yeah, I would say, of course, when you remove a 5% lump sum incentive bonus, it's going to decrease the business case for accelerating one's transition to downside risk. But that being said, from Northwestern's perspective, aside from how we think about the speed with which we take on more and more risk, we're still very much on our APM journey. We're invested in developing competencies like care coordination, completing annual wellness visits, robust analytics, the things that are going to help us succeed under increased downside risk. So that's something that hasn't and won't change.
Thank you. And Sandy?
Thank you. So I just want to start, but it's a little frightening to have the question, how will the end of the incentive payment affect us? We are strongly supporting legislation that would extend these 5% incentive payments. So we really, really hope we won't have to face the end and that Congress will extend them. So I just want to say that to start with. I've seen a lot of the Q's and A's coming in that talk about why is sort of CMS doing this to us. It's not CMS, actually, it's Congress that needs to act. So for physicians in APMs, this 5% incentive payment has really been the only way a lot of them can be paid for delivering high value services that aren't adequately supported by the current system. Calling it an incentive payment can actually be sort of a misnomer, because the 5% can do more to reduce the amount of money physicians would otherwise lose by participating in the APM instead of actually paying them more to do it. Physicians also face significant transition costs in participating in APMs. I think Jessica and Aisha have both outlined this already, and also Karen in the previous question. For example, if an APM pays for enhanced care management services, the physician practice still has to recruit, hire, and train staff to perform those functions. And that's going to require incurring significant costs before the services and payments can begin. So the 5% payment can help offset those transitional costs, and without it, a lot of physicians just wouldn't be able to make those kinds of investments. The expiration of the 5% payments means it would be even more difficult than it is today for physicians to participate in APMs that rely principally on shared savings payments. So consequently, we think it's really important for CMS to modify its APMs to include payments upfront for new services and funding for transitional costs, so that physicians will have the ability to implement better approaches to care delivery. Moreover, the APM payments need to be designed in a way that enables physicians in each specialty to deliver specialty-specific services for the kinds of patients those physicians treat. The AMA has developed a method for doing this in the Shared Savings Program that we're calling Payments for Accountable Specialty Care, or PASC. Under PASC, a specialist could receive an Enhanced Condition Services Payment, or ECS payment, for delivering specific types of services to a patient in a way that's designed to improve outcomes and reduce avoidable spending. Health equity would be improved by providing higher ECS payments for the care of patients who have complex conditions or who are at higher risk for poor health outcomes due to health-related social needs or other factors. Thanks.
That's really helpful perspective. Thank you, Sandy. And Karen, I will turn it to you to finish out with this question.
Thank you. So I would first say that this is not in a silo, right? You can't ignore the sort of overall external environment. Practices are looking at a slew of new and continuing cuts for 2023. The MIPS exceptional threshold, decrease in the conversion factor by about 4.5%, possibly some upcoming changes to the MEI. You have sequestration, PAYGO, whatever the impact is on your specialty, again, from the fee schedule that was just released, really high pressures on staff costs and inflation, expenses and losses related to the pandemic, and then the 5% APM bonus loss. So, these practices are taking fairly significant financial risks in advanced alternative payment models. There's going to be nothing to replace that lost 5%. And I think, as CMOI already pointed out, that QPs by definition are required to forego, are not eligible for any MIPS bonuses. The 5%, I think, has been alluded to by previous panelists. That really was crucial for extra staffing costs and for infrastructure. It was also a crucial cushion for those practices who may have experienced some losses within the APM itself. You're left with less money to invest in care and practice transformation. I've mentioned earlier, even with the 5%, that few of the OCM practices felt that they could take on the two-sided risk, and we're we're concerned about what that's going to do to the appeal of the EOM without this 5% bonus. And you put that all together, and it may simply be too much for a lot of practices to continue in advanced APMs. So those are my comments for that question. Thank you.
Thank you, Karen. That's that really illustrates what I was driving at on the earlier slide that showed the graph, was that it was very, very simplified. And I think even within the factors that were shown there, and you're bringing in some additional ones that were not represented on that slide. So that's a fair point as well. I do see a couple of other questions in the Q&A that I think would be helpful to go through very quickly, just to add some clarification on a couple of points. So one is, are there any incentives uniquely for AAPM participants starting in 2024 and beyond? And if not, will those participants once again be able to participate in MIPS and those bonuses and receive those payment adjustments? So as the timeline slide showed, in 2024, that will be the last year of the APM incentive payment, the 5% bonus under current law legislation. And then in payment year 2025, there is no financial incentive. The exclusion from MIPS for QPs does continue. And then starting in 2026, the conversion factor update, which right now is the same for everybody, will split into two, and you'll get a higher one if you are a QP versus if you are not a QP, but QPs remain excluded from MIPS. And so basically you either are a QP or you may be eligible to MIPS if you meet the other criteria for MIPS eligibility. So they are mutually exclusive under MACRA. And then there was an additional question around sort of a related matter, whether CMMI or CMS plans to publish a list of cert requirements for individual APMs. So this is where the quality payment program and the individual APMs kind of bump up against each other a little bit. There are requirements under the quality payment program that to be an advanced APM, a particular APM has to have a cert requirement, certified EHR technology specifically is what that means. But how that requirement looks is going to differ by APM, and it really is what is the specific need. And so there are other parts of CMS that sort of design and implement any individual advanced alternative payment model. And so what those criteria look like, whether it's the financial risk criteria, whether it's the quality measures tied to payment, whether it is certified EHR technology, those really are all unique to each APM. So I would say, point you in the direction of looking to those to see exactly how those things look for the specific APM in question. And I think we are a little bit ahead, which might serve us well in moving to our last question. So we can transition to that final question for this group and go to the next slide. And so the last question is, are there perceived advantages of participating in MIPS versus participating in an advanced APM? And so Karen, I'm gonna go backwards and start with you this time, as I understand this may be a question that you have more to weigh in on.
Thank you. So I think the way that I'll approach this is sort of by looking at the pros and cons of both MIPS and APMs compared to each other. And so, as practices are looking at this, and I think the heart of the question that CMS is trying to get to here is, what are people thinking about as they're considering what they're going to do moving forward? And so as you're looking at MIPS, sort of in the pool of pros for MIPS is, there's for a practice, there's often lower administrative cost. There can be much less financial risk, basing this on historical performance and compared to the potential loss in an advanced APM. And there's more potential upside for strong practices. Some of the drawbacks of MIPS is the historical, for example, the historical MIPS bonus for a perfect score was around 2%. And much of that came from the now defunct exceptional performance pool, which has also gone away. So we can't know what the upside bonuses are going to be in MIPS going forward. CMS can certainly make some very educated estimates, but as we've clearly seen with the pandemic and other events, you never know what's going to come and hit you. Some more drawbacks in MIPS. There's, potentially more competition from stronger performers in what's essentially a zero-sum game, especially if you have strong practices leaving advanced APMs and moving into MIPS. Smaller and rural practices definitely do not tend to do as well as larger and better resource practices. Again, despite CMS has tried to help those practices with bonus points and special exceptions within MIPS and extra resources. But when you look at, again, at the historical performances there, they have not done as well as the larger, better resource practices. Then the obvious, MIPS has the 0.25% annual update moving forward versus the 0.75 for APMs. And then what may be another drawback for some practices is that, there's new reporting requirements and some reporting uncertainty in MIPS when you look at things like the new MIPS value pathways, the MVPs, along with the associated required subgroup reporting moving forward, things like hardship exceptions, exemptions, et cetera. And then when you turn and you look at APM, some of the things that you're thinking about is, there's usually higher administrative costs and requirements, as several people have mentioned here today, associated with reporting additional clinical and quality data. Even other external factors like the MSSPs may look more attractive with the new 2023 proposals that CMS has laid out in the fee schedule, including for smaller practices. And then if you look at this through the lens of the, enhancing oncology model, which is the new APM that CMMI has proposed for oncology, you're asking yourself, how much do I have to save before I qualify for a payment bonus? And the way the EOM is set up is there's a 98% savings threshold. So you have to hit 98% before you could think about getting a performance bonus. And even underneath that 98%, there's a further, what they refer to as a neutral zone. In terms of the quality scoring within the EOM, a higher quality score may slightly decrease any recruitment if you end up owing money, but it has no positive impact on your performance-based payment. And so the way that works is that poor quality scores have significantly more impact than higher quality scores. So, for high quality, as I mentioned, you don't get a financial bump in your performance payment, but for poor quality, you get additional financial loss in your recoupment. So those are some of the things that, that I think folks are thinking about as they're sort of looking at MIPS versus APMs. And, one of the things that we're doing as a medical specialty society to help our members, as new innovations and alternative payment models are introduced, like EOM, the OCM in the past, is, we're working to develop and adopt complementary innovations in care delivery, which practices can use to show payers that they're meeting the highest evidence-based measurement of high quality cancer care. So, for example, the patient-centered cancer care certification pilot, it's not a payment model, but it equips oncology practices with structural care delivery framework that's designed to address patient access to care, increase care coordination, and enhance overall quality. So those are the comments that we're thinking about in terms of looking at MIPS versus APMs for our practices. And so I will end there.
Thank you, Karen. That is really helpful. Continuing in reverse order, Sandy, I will turn to you to answer this question next. Perceived advantages of participating in MIPS versus advanced APMs.
Thank you. I'm not sure there really are any, to be honest. Our impression is really that most physicians would prefer to be in a well-designed APM than to be in MIPS. And because it is mostly budget neutral, and next year, as Karen said, it's going to be totally budget neutral because the exceptional performance threshold funds will be ending, again, according to the underlying macro law. The positive adjustments in MIPS have already been far below the maximum that was in MACRA, and they've really been much smaller than the 5% QP payment that was available. So it's tough to see any real advantage there. One advantage of MIPS is, of course, it doesn't require significant downside financial risk to participate in MIPS. There is risk because there's a lot of administrative costs of reporting and and all that, but it's not the same as the downside financial risk of repaying CMS that you get in an advanced APM. But we really think the best approach is to create good APMs so that all physicians who want to participate in them will have a meaningful opportunity to do that instead of being in MIPS.
Great, thank you. That's really helpful. And Jessica, continue in reverse order.
Yeah, I'm gonna make this easy for everyone and just say, I think Sandy and Karen nailed it. No edits.
Okay, great. And Aisha.
Yeah, I'm going to echo some of the same points. I think overall providers would rather be in an APM, whether it is advanced or a non-advanced track, and we need to make sure that we have the right incentives to move there. I think one thing to be cognizant of is where we face challenges, we kind of face it in both the APM and on the MIPS realm. So if I think about types of providers that we want to pull into models, think about small and rural, we haven't figured out those challenges in the MIPS perspective or in the APM perspective. And I appreciate the work CMS has done to think about bringing more providers into APMs, particularly small and rural, those vulnerable providers. It's always been a challenge to measure them in MIPS as well, but I think if we can solve some of the challenges and pull them into APMs, it'll be better than trying to solve for it within MIPS. I just want to raise another point that we haven't really talked about much in terms of this bonus. I appreciate that Sandy mentioned that we are very much asking Congress to extend the bonuses, but the other piece that we are asking is to reconsider the thresholds to qualify for the bonus. They will become too high, and those thresholds also apply to that differential update of the 0.75 versus the 0.25. So that's another thing that we are asking Congress that is a real challenge in receiving the better update or the advanced APM bonus. So lowering those thresholds, and the thresholds tie back to things like types of providers that are in the model. So if you're an ACO and you bring more specialists in, it's really hard for you to meet those thresholds. And so that's sort of another piece of thinking about designing, as Sandy said, designing really well models so that we're getting all providers in and not just some.
Okay, that's really helpful. Thank you very much. So that was our final question. I want to say thank you again to all of our speakers today. Your expertise and reactions on how the payment changes will affect you and your organizations and members are really insightful. I'm now going to hand the floor back to Ellen to close our event today.
Thank you so much, Anne, and our panelists. Really appreciate that excellent input and perspective really on the APM incentive payment and participation in APMs more broadly. I did want to note just one thing that came up a couple of times in the chat and otherwise, the 5% incentive payment, the period of time that that's effective, it's actually statutory. And I think that's something that Anne alluded to, but just wanted to underscore that again. So CMS does not make a decision whether to continue that or not. That would be a statutory provision. And it sounds like many of our panel participants are exploring options there, which is great to hear. I know we're almost out of time, but just wanted to let you know that we will be synthesizing the conversation today and have a summary. We also wanted to make sure that folks were aware that they could submit additional input in the QPP. I don't know if folks can display that, but the Quality Payment Program APM Help Desk email address that was included in the slides, that is one source. The other is we really, really encourage you to provide comments. Those will be the official input to the 2023 physician fee schedule notice of proposed rulemaking. So again, if you can provide comments on the rule, that would be incredibly helpful. You will see the RFI included within the rule. I also wanted to ask you if you have a few minutes to please participate in a survey for today's event by using your phone camera to scan the QR code or by clicking on the link in the chat window. You see that up on the screen now. It will only take a few minutes. Thank you again for participating today, and in particular to Anne and our panelists. I thought it was an incredibly helpful and rich discussion. Did want to say that if you want to continue to receive CMMI email updates on upcoming events or model participation opportunities, please go on our website and join our listserv. And also follow us on Twitter at CMS Innovates. That's everything for today. Thank you again for participating. We really appreciate it.